I really want to tell you a story, so I guess I'm going to, because a lot of this you're going to have to read, and I'll never get through it all, but it's all there. My favorite British insult. I was watching a TV show years ago, and there were two British blokes fighting over something, some historical show. And one of the guys says, Sam, I would not like to say that you are totally wrong. However, I would like to say that I am totally right. And I'm like, that to me is just beautiful British stuff. Sorry, I had to share it. Patients like humor, okay? I'm not naturally funny. I got to work at it. I learned it from one of my first mentors. Honestly, I got so many lines that they want you to drop F-bombs on them. We're going to drop some F-bombs on you, all that stuff. So they love that stuff. Anyway, understanding SVT is a clinically significant event. I'm gonna roll fast. Rationale for foam sclerotherapy is primary treatment, clinical experience, rapid pain relief, enhanced healing, comparative insight into other SVT management strategies. I believe SVT is an analog for how we understand foam sclerotherapy and how it should be performed. And I will tie this together. Definition: thrombosis of a superficial vein without iatrogenic cause, commonly underrecognized, can extend to DVT. I think most of us are familiar with SVT. Painful, tender, palpable cord, often overlying erythema pigment, non-compressible on an ultrasound. What are we all taught to do? Oh, well, don't touch that patient, Alistair. Put them in some compression, put them on blood thinner, and let them suffer and hurt like crazy, because normally they're in a lot of pain. Some of them can be in pain for weeks or months. I've had people come in with chronic SVT of over 6 months with daily, nearly constant pain, and we've got them out of pain within 12 hours. And I'll just kind of cut to the chase. So SVT, there's endothelial injury, venous stasis, Urquhart's triad. Basically, it's a clot in a vein. Again, I'm going to roll through this. What is the difference between de novo SVT and foam sclerotherapy? Well, there's clot in a vein. It's sitting there, but the wall is intact, and the physiology of the body and the vein is intact. Okay, and the body wants to recanalize the vein. All right. So it's constantly trying to recanalize the vein, and with that comes fibrinolysis and enzymes, and pain comes with that process. The difference between a foam sclerotherapy and a de novo SVT is we are creating an SVT, but the difference is we're killing the wall of the vein along with it. And when you do that, you stop the physiologic process of recanalization. Any questions about that? Does that make sense? That's the fundamental difference. So these are the practical points, and I'll leave all this. You can read it later. The practical points is I do 2 INDs a year in my practice. Most people think it's de rigueur. If I'm doing foam, I'm draining coagulum. Those folks, you're under-treating your patients. You're creating an SVT. You're injecting foam. You're under-injecting it. You're not re-injecting it. One case of session of foam sclerotherapy is no case. For the same reason, nobody in this room, the cosmetic sclerotherapist, wouldn't do one sclerotherapy session on a cosmetic leg. Why do we accept that in medical? There's this mentality of one and done. Okay, that's great for a gallbladder surgeons, because I are one, but I don't use blades. But it doesn't work in vein care. You need to do at least 2 sessions a leg. You need to do several coats of paint, right? When you're doing cosmetic sclerotherapy, you're not going to get it all done in one. So what most colleagues are doing what about all the thrombophlebitis? You're undertreating your patient. You're not killing the wall of the vein. It's like injuring an animal, and there's a flailing horse. Sorry for the animal lovers, but I use analogies. And you got this flailing horse in the vein that's hurting the patient, and you need to put it out of its misery. I'm sorry. You need to foam it again. I challenge all you thermal ablationists, inject foam after you thermally ablated GSV a week later, 2 weeks, 3 weeks, whatever. Foam's an angiographic agent. You'll learn a lot when you do that. And you will find that foam goes if you inject foam here, it will go all the way up to the junction. So we often think that veins are closed because it looks like they're closed on ultrasound. If a vein is spongy, and I'm not here to talk about tips and tricks, it's hard, Haroon, it's hard. But if they're spongy, more than 20%, that means they're not dead. It means you got a flailing animal in there, and it's possible that the patient might develop pain. You have to inject enough foam to get to the point of non-sponginess. That's what we call it. So you have to do several coats of paint for the same reason you would do it cosmetically. Let's keep going. Traditional management, we've already been through. Let the patient suffer. This was a state-of-the-art article that came out, which is the same damn thing, right? Just put them on anticoagulation. Why are there no procedural treatments for severe SVT? Who in the room's done percutaneous declots of deep veins in the legs? Anybody? Probably some of the vascular surgeons and the IRs in here. We've been doing thrombolysis and mechanical thrombectomy of grafts and veins for decades, but SVT risk progression to DVT and PE, yet we have no procedural options for SVT. In 2025, many here are familiar with surgical ligation, of the S at the top of the GSV, top of the vein, and then they'll declot it. Well, you can do that with foam, or you can do that with thermal ablation. So I know I'm going to start losing many of you here. There's a pharma bias and a pill mentality. Why is that? There's a lot of money when people are put on anticoagulation, especially for long periods of time or life. Systemic and economic bias, regulatory disparity, physician and training norms, current procedural landscape, medical landscape favors pharma over mechanical. So I've been through this already. If someone comes in with de novo SVT, it's not wrong to inject foam. In fact, it's the best time to inject foam because you have a filling defect in here and all your foam will be put exactly where it needs to be, which is along the intima of the vein, right? So it's the best time to do it. And I'm not the only one that's done this. I'm just the loudest about it. That's all. There are other docs that do this, but they keep it to themselves. So this is a typical case example. We inject them and they feel better. I'm going to move a little quicker here. Pain relief usually in 24 to 48 hours. The theory is that the foam stops fibrinolysis and recanalisation physiology via complete endothelial ablation. Foam displaces the inflammatory mediators, and I'll let you guys kind of roll through that if you have nothing left to do later. But I was very fortunate because Kourosh Parsi, MD, PhD dermatologist from Dr. Vun's country, consider him honestly a real pioneer in foam from a basic science and a clinical standpoint. He told me about this article he was going to be publishing last, and he makes a distinction. You should all read this article. It's like 2 weeks old. Between sclerothrombus, sclerocoagulum, SVT, and, who here is familiar with deep vein sclerosis? Who's not here? We're going to embarrass some people. Who's not familiar with deep vein sclerosis? I know several of you are not. We're not, he will tell you that most of the DVT, like 99% of it after foam in the deep vein or in the tibial veins is deep vein sclerosis because he correlated it with D-dimer and all that. It's a landmark article if you're a foam sclerotherapist, but we don't even call it DVT anymore. We call it deep vein sclerosis. So just because you see a filling defect in the calf vein does not necessarily mean that it's clot, interestingly enough. So I'm not going to go through all this, but the bottom line is he did some electron microscopy of what happens after we do foam sclerotherapy. I recommend you look at it. And it basically gave me scientific support for the notion that I've always had that we have to stop the recanalization physiology. And the professor, to my absolute thrill, said I was spot on because I sent him my talk. So you guys can read it. I'm a recovering detail guy, so I put it all in there. Anyways, because of how we do things, there's greater accessibility to fibrinolytic enzymes, and I'll let you guys go through it. Sclerosin-induced thrombi are biochemically accessible but structurally resilient, providing unique advantage in venous ablation therapy. So there's a fundamental difference between the clot that we create when we do foam sclerotherapy versus de novo clot. And he gets into that very interestingly. Anyways, venous sclerosis may in fact occur in the presence or absence of intravascular blood. That's an interesting concept. He's demonstrated deep vein sclerosis, as we've talked about. I'm going to keep going, or we've touched on really. So I like this, and yes, I bow to AI. It's amazing stuff. Look what it came up with. The parsonary of foam decoding the Sclero Dictionary. Sclerobabble, Parsi's Field Guide to Foam Speak. I kind of like that. Sclerothrombus, sclerocoagulum, venous thrombosis, venous sclerosis, and deep vein sclerosis. I recommend you guys look at this and look at any article. He had published a zillion, but any article from Parsi's well worth looking at. This is a comparative overview of foam sclerotherapy. Oh my God, I got a typo in foam sclerotherapy. I can't believe that. Anyways, compared to NSAIDs and anticoagulation, I'm going to move on. To fully understand foam sclerotherapy, inject foam into SVT. Iatrogenic SVT is the result of incomplete foam treatment. You're leaving channels intact. It's all in there. Phlebitis, pain, SVT-like symptoms, persistent pigment, it's all due to partially closed or spongy veins. Your technologist will tell you, the vein's closed, doctor, the vein's closed, doctor. It's not closed. If there's persistent pigment, 100% of the time, there's an open vein in or under the area of pigment. Inject foam in that closed vein, and you'll see the foam go all through there, okay? It's not easy to tell a closed vein on ultrasound. So you stop phlebitis. We fight fire with fire. If they're hurting or tender, yeah, that's right, patient, I'm going to inject more foam into that thing that hurts. And when I do that, it gets better. Don't let your patients suffer. So I think this is probably more repetitious. There are histological studies on, did we use enough concentration of our foam? Don't spend so much time thinking about the concentration. I think it's entirely misguided, with apologies to the French, because they use different concentration for every different size vein. Use 1% polydocanol and just get good at it. And where I'm going with this is you can see on your ultrasound whether the intima is intact. We all recognize it as a white line. If you pay attention, you will see disruption in the intima on the ultrasound, and you'll know where you need to put a repeat foam. If you got a white line there, the animal's not dead. Got to put it out of its misery. Fight fire with fire. Oh boy. Potential risks, I don't think there are any, honestly. Conclusions and takeaways: inject foam into SVT, help your patients, and I'll leave it at that.